Hello, Dr. Ayub. Let me finish the GYN pathology, and it is a continuation from my previous lectures. So today I am going to cover the primary malignant ovarian neoplasm and the secondary or metastatic ovarian neoplasm. So in primary malignant ovarian neoplasm, there is a big list of this name of the neoplasms. So here I want to give you first in systemic way that what are the etiology of these primary malignant ovarian neoplasms. So we have to understand that the patient, the GYN patient will go to the doctor in the different age group, right? The young age group, middle age group and the old age group, and with the different pathologies. And this malignant pathology in the ovary is very dangerous, and it is the fifth leading cause of death. Okay, and lot of people, they have this disease but they don't figure it out at the beginning that they have something wrong, because the pelvic organ, a lot of pelvic organs are there, and lot of causes are there to cause pain in the pelvis, especially for the female, and they ignore it. They feel like if some patients is having pain, so they may feel like, okay, this pain can be from my cramping of the uterus, can be from my UTI, cystitis, or PID, or constipation. So they ignore it. They ignore it. 6 months, 1 year is gone, and suddenly something works. That why I'm feeling like that? I'm losing my weight, and I don't feel I'm healthy. I'm feeling nausea, and why there is this constant pain, and my pelvis is feeling, I feel like it is filled in, swollen, and I don't feel good. My energy is gone. Okay, then they will go to the doctor, and the doctor will take a lot of history, and they will send it for initial tests, and finally they found that there is a cancer. And when it is recognized, so then it is already stage 3, 4, means it is already metastasized. Okay, that is the bad part. And the primary cancer is more than the metastatic cancer in the ovaries. Okay, let's see who are the most common people, and what are the risk factors, and what are the signs, symptoms of this ovarian primary malignant neoplasms. The etiology, the ovarian cancer is the fifth most common cancer among women in the USA, and it is the leading cause of death from gynecologic cancer because it is difficult to detect. It is difficult to detect because initially the patient does not take care of themselves. They don't go to the doctor. They don't take it seriously. Okay, so this is the fifth most common cancer and leading cause of death from gynecologic cancer. And the risk factors, it is mostly in the middle age group, 40 years to 60 years old, and the double the risk if mother or sisters had ovarian carcinoma, and nulliparous. Nullipara means never had the pregnancy up to or over more than 24 weeks. Parity we consider if the pregnancy extend beyond the 24 weeks, then patient is having one para. Okay? And the nulli means absent, no parity. No parity means no a big baby or term baby, preterm baby. No babies carrying in the uterus more than 24 weeks. Nulliparities. And maybe a reduced risk for women who are on low dose oral contraceptives. So this is a research conclusion, but it is maybe controversial, but it is true that the birth control pills can cause a lot of other diseases, including the DVT. But low dose birth control pill may be a reduced risk for the woman. Okay? So now, signs and symptoms. Unfortunately, the most ovarian cancer present asymptomatic until the disease has metastasized. That means stage 3 and 4. The late symptoms are weight loss, nausea, and pelvic pain. So this is important. This is weight loss. Sudden weight loss at any age is not a good disease. It's not a good sign symptoms. Weight loss, you have to look for causes of the weight loss. Now, the method of spread. What are the method of spread of this cancer? And we know that the cancer and the infection, they love the two systems, that is lymphatic system and hematogenous, the blood circulations. Okay, they love to spread in the body through the lymphatics and the blood, mostly the venous blood. They carry the germs from periphery towards the center. And the lymphatic system, they receive the extra amount of interstitial fluid, that is lymph, and from the tissue level, mostly the superficial tissue level and the deep, and finally they dump this fluid, lymphatic fluid, into the venous system. Okay, finally, ultimately, all the cancer cells and the infectious organisms or materials, they are dumped into the venous system. Okay, so method of spread. The cancer is spread via the ovarian vein and the pelvic lymph nodes. Okay, so then method of spread. So one is ovarian vein. And lymph nodes. Okay, and the cancer spreads to the adnexa and the bowel first, followed by the lungs and the liver. Okay, initial spread to the adnexa and bowel. followed by the lungs and liver. Anytime a malignancy is suspected, image the para-aortic lymph nodes, porta-hepatic lymph nodes, and the liver. And ascites is found in the Morrison's pouch and the posterior cul-de-sacs. Okay, so now if it is suspected, this is very important for the sonographers. If it is suspected, then scan pelvic lymph nodes, para-aortic lymph nodes, porta-hepatic lymph nodes, liver. Look for the free fluid, means ascites, in the peritoneal cavity, posterior cul-de-sac, and Morrison's pouch. Okay, you can also see fluid collection in the paracolic gutter, and when it is too much, then you can see it is in the subphrenic, right and left subphrenic area. Okay, so we understood that we need to check the lymphatic nodes. The lymphatic nodes from the pelvic group of lymph nodes, usually around the iliac vessels or hypogastric vessels. Then para-aortic lymph nodes. That para-aortic lymph nodes is by the side of the aorta and the IVC, and around the SMA. Sometimes we call it sandwich sign of the SMA, superior mesenteric artery, and porta hepatis and the liver. Okay, so now let me give you the idea. One more thing I like to add here, and that is ovarian vein. We have 2 ovary and the 2 ovarian vein. Okay, that is right and the left. The right ovary, the right ovarian vein drains into the IVC directly. The left ovarian vein drains blood to the left renal vein first. Then left renal vein drains into IVC. Okay, so this is important. Why? Because we need to pay attention. If there is a suspicious mass in the left side of the ovary, so we need to check the left renal vein and the IVC, because the metastasis can take place in the IVC. Okay, so this is important. And I want to show you the way how we're going to see the positive findings if the ovary has cancer. Okay, I like to show you here. Let me take this out again. Okay, the first of all, we need to understand the iliac group of lymph nodes. Iliac group of lymph nodes. How we going to see the iliac group of lymph nodes? Understand that so this is IVC. These are the common iliac veins, right and left, and this is internal iliac veins, also known as hypogastric veins. And these are the external iliac vein. This hypogastric vein with the hypogastric artery, that is internal iliac artery, sonographically we can see in this view when we scan the adnexa. When we scan the adnexa, you will see the blood vessels. Okay? And one is jumping or pulsatile, another is not pulsatile. So these are the two. So maybe this is artery, internal iliac artery, and this is vein. And we know that the ovary normally we found here. We found the ovary here. And when there is an ovarial cancer, so we need to see that their internal iliac group of lymph nodes, those are by the side they are found enlarged. So these are the lymph node. So you should see the lymph node enlargement around it. Okay, when you see this, the lymph node, when it is enlarged, we call it lymph adenopathy. And then click the color, you might see the hypervascular, and it's enlarged, swollen and darker. Okay, so that is one group of lymph nodes. You will see it Now I will show you the para-aortic lymph nodes. How are you going to scan the para-aortic lymph nodes? Okay, I am in the SAS view of the aorta. So okay, so this is aorta. This is aorta, this is celiac trunk, and this is SMA. And you should know that this is left renal vein. Okay, and the body of pancreas is here with the splenic vein. So this is body of pancreas and this is splenic vein. Okay, and when there is a para-aortic group of lymph nodes are enlarged, so you will see the lymph nodes. Okay, you will see the para-aortic group of lymph nodes are enlarged and is visible around the aorta and around the SMA. And the way it is around the SMA, we call it sandwich sign. Okay, so these are the lymph adenopathy. Lymph adenopathy. Okay, so now I will show you the portahepatis. Portahepatic lymph adenopathy, lymph nodes. How are we going to see it? You will see like that. Okay, so this is as view of the liver. So this is portahepatis. Here you will see the portal vein. Okay, and hepatic artery and the bile duct over here. So Mickey Mouse sign. And this is the portahepatis area, because the through which this portal tried. So this is hepatic artery, this is bile duct. And if you see okay, you see the unusual masses in the at the portahepatis. So these are lymph node enlargement. Okay, if you see a suspicious mass in the abdomen or in the pelvis, at the same time you see the lymph adenopathy at the portahepatis, so then you have to suspect that it is the lymph adenopathy at the portahepatis. Most of the time it is due to metastasis. Okay, so now if there is a metastasis inside the liver, so you will scan the liver and you will see inside the liver there is some solid mass, and it could be target inside, target sign, or bullseye. Okay, so if you see intrahepatic, so this is the liver, intrahepatic lymph node and metastasis. So then you will see so when there is a secondary metastasis inside the liver, so you will see there's a mass inside the liver. Okay, so you might see a target sign. Okay, you might see like that. So this is the way you will evaluate the metastatic lymphadenopathy and the liver metastasis. Now I will show you how you're going to look for the ascitic fluid. Okay, look for ascitic fluid in ovarian carcinoma. So first of all, I like to show you the posterior cul-de-sac. So this is bladder, this is uterus, and this is rectum. This is posterior cul-de-sac, and when you see the fluid accumulation in the posterior cul-de-sac, then it will be anechoic. Okay, and at the same time you will see something inside the ovary, and you may not see the ovary, but because of the huge collection. So this is posterior cul-de-sac fluid. Also it is known as pouch of Douglas. Okay, and this is anterior cul-de-sac, is here between the bladder and the uterus. So this is anterior cul-de-sac. Okay, so that's the way we need to see this fluid. And another one, so this is in pelvic area, and in the abdomen this is liver, this is right kidney, and this is the subhepatic space where the fluid accumulates, and this space is known as